Hello, everyone. My name is Jay Buss. I'm the National Clinical Director for our outpatient division with Aegis Therapies. And thank you and welcome to this month's Impact with the Aegis Therapies webinar. I think we'll probably just wait maybe one more minute before we go ahead and get started. Looks like there's a couple people signing in, so we'll just give them 1 minute and then we'll get started. All right, well, I think it's slowing down now, so we can go ahead and get started. So again, welcome to Aegis Therapies Monthly Impact with Aegis webinar. This month is the theme is kind of in honor of the 4th of July. We wanted to take this opportunity to discuss the assessments and interventions for the higher functioning adult. These are the clients that might not have an obvious injury or deficit that sometimes require a little bit more digging to identify the need for therapy. So just a couple of, before I get into the housekeeping items, next slide, Kim.
Can you see?
Now I still see the very first celebrating independence slide.
Oh,
There we go.
all right.
So our presenters today, they're each gonna tell us a little bit about themselves a little bit later, but we have Patty Wyke, the VP of Integrated Care and PT by background, Jenny Blankenberger, speech therapist and outpatient speech therapist at our outpatient clinic in Carmi, Illinois, and we have Kim Collins, senior area manager in our direct bill, also known as our outpatient division. So next slide, please. Couple of housekeeping items before we go on. First, you'll see a couple of attachments included in the GoToWebinar. You should see them on the right-hand side of your screen. There is the PDF of this presentation. You have the brochure that was sent out initially with the webinar registration. The handout for our OT and CODA team, that includes the QR code to take the quiz, and also the participant handout. Also, just general housekeeping, all lines are on mute. If you have any questions throughout the presentation, you can use the questions feature, also in the top right-hand corner of your screen, to ask your question or make any comments. Make sure you use your own unique identifying login so that we have record of your attendance. Otherwise, you will not get a certificate. Please give Shyla up to 2 weeks. And just in case you don't know who Shyla is, Shyla Hamrick is the executive assistant for the clinical department at Aegis Therapies. But please give her up to 2 weeks to process certificates. The ASHA bubble sheet, which is also included in the attachments, is for speech therapists only. And please remember to return those to Shyla as well. And as I mentioned briefly a second ago, for OTs and CODAs, there is a quiz, that will be sent to you tomorrow. If you're in a hurry, you have the QR code and the attachments to take that quiz today, but you must take this and pass this in order to get CEU credit. You do get 2 tries, and if you need to have a reset, you would reach out to Shyla Hamrick. And again, all questions throughout the presentation today should be done in the chat feature, but after that, or in addition to that, any questions and ASHA bubble sheets can be sent to Shyla Hamrick. So you have that email address right there. So our objectives today, our objectives are that the participants will be able to identify at least 3 PT, OT, and speech standardized assessments that are appropriate for the higher functioning adult, and also be able to identify intervention strategies appropriate for the higher functioning adult. Participants will be able to articulate methods for identifying therapy needs within the high functioning population, and learners will understand how to document skilled services and medical necessity for the high functioning adult patient. With that, I turn it over to you, Patty.
Yeah, hi, thank you, and thanks everyone for joining. My name is Patty Wyke. I am a PT by background. I worked for Aegis for over 10 years. My role within the organization supports our integrated model across the care continuum with a focus on services to the higher functioning adult. You know, often therapists trained in the acute or subacute setting, like the SNF, are working primarily with younger people and happen to have some older adults on their caseload, really tend to struggle with identification of need in a higher functioning adult. Those adults that are playing pickleball, traveling, golfing, and who really appear to be living their best life. We may even have internal biases that some complaints from older adults are just a part of getting older and that they should just be tolerated, right? But those subtle changes, if left unaddressed, can lead to something larger. The focus should be to be very proactive, to catch things early, and to really identify some of those needs, again, that are very subtle, that could lead to something more significant. Age by itself is not a reason to slow down, but it can be a self-fulfilling prophecy. We hear it from family members and individuals frequently. I had a son of a client tell me recently, no, please don't address the fall that mom had because falling is a part of getting older. Or you hear, I'm not going to do that anymore because I'm too old. And you have to question what came first, the balance, strength, or endurance issue that you're seeing, or that mental self-talk that said that they should slow down or they should stop doing some things because they're getting older. So if you're thinking about how to identify needs in higher functioning adults, acceptance and that age is a reason for pain, immobility, and isolation is kind of the first one. If you hear that kind of talk when you're taking maybe a social history or doing a screen of a client and you're hearing that kind of talk, decreased mobility, balance issues, falls, chronic pain, reduced strength and endurance, some of the obvious things, of course, like post-surgical rehab, recovery from illness or injury, changes in activity level, hobbies, daily events that used to bring joy to that individual and now they're not doing it anymore, like visiting or playing with grandchildren, dancing, pickleball, traveling. It's kind of the why that we want to understand, right? What's the why behind that, and could physical therapy or OT or speech help that individual? Next slide. So higher functioning adults often need a test that's more sensitive to their ability. Here's a few. I'm sure you all have used many of these, the TUG test, the 6-minute walk test, and then you'll see to the right that it really explains kind of what that test is measuring. The Berg Balance Scale, the Short Physical Performance Battery, Functional Reach Test, 30-second chair stand test, the Physical Activity Scale for the elderly, which is a good one, and the Community Balance and Mobility Scale. If you haven't heard of these, you know, they're very readily available online, and we encourage you to go out and do some research. The 3-minute backward walk test is one very rarely used with older adults because we get scared, right? All of us, we don't want anyone to fall while we're treating them. But a really good test for mobility, it really engages lower extremity strength and engages the vestibular system. And then the 1 rep max measure, and that measures strength. It's one we're going to focus on today, and it also calls into the first polling question. So Shyla, you want to send that out? So our first polling question, how many of you use the 1 rep max to determine proper dosing for your strengthening regimen with older adults? You could just select one of those, and we're going to, and no judgment here, just curious. So you select, I sometimes do, I always do, or I never do. Are we getting some results in, Shyla?
We are about
Good.
73% have voted,
Okay,
so I'm going to
perfect.
go ahead and close the poll now. And 26% of you said I sometimes do, 6% said I always do, and 68% said I never do.
Okay. Well, congratulations to those of you. And honestly, that's what I anticipated that we would say. So that's why we want to talk about it today, right? Of how to use the 1 rep max as a measure. And we're going to focus on it today. It's often overlooked, and overlooking it often results in underdosing and not challenging the body's reserve or resiliency, which can result in a suboptimal outcome. So the 1 rep max is a standard measure. It assesses the maximum strength of a muscle or a muscle group. It determines the maximum weight a person can lift for 1 complete repetition of a given exercise. For older adults, this test can provide really valuable information about the client's strength level and help guide our strength training and rehab programs. Interestingly, only 12% of individuals over the age of 60 report participating in exercise programs that meet the federal standards for building strength and power. Only 5% of individuals report this type of exercise regimen when they're over the age of 85. So you can understand that if we're not challenging our body to grow muscle strength, to grow muscle power, it's really no surprise that over time, that individual would lose functional health. They would have a decline in their functional health because they're not working to maintain or to build their muscle strength and power. Determining the 1 rep max. Now, we all know that is the maximum weight that you can lift with a muscle or muscle group for 1 repetition. Hard to determine right in an older adult because sometimes we don't want to go clear up to that. It's too stressful. It's, you might be afraid to do that with a particular client. There are equations to estimate the 1 rep max. I'm not going to go through those today, but please do research them. There's one by Matt Brzezinski. There's Epley's formula and Lander's formula. So they are easily available online of equations to calculate that 1 rep max. And there's also apps out there that you can use to easily calculate that 1 rep max. And the next slide. So 1 rep max living. I'm going to talk about that for a little bit and what that means. But first let's think about a clinic you've seen, especially a clinic that specializes in older adults. We've all seen therapists who use 1 to 2 pound weights for 10 reps over and over and over again. And are they really building muscle strength, muscle power, muscle endurance by using that low weight without understanding, is that the person's 1 rep max? Underdosing in intensity and frequency is prevalent when working with the older adult. It results in a gradual decline in functional health, including their reserve and their resilience. Despite even having a course of physical therapy, right? The resident gets better, the patient gets better because time has passed. But did we really increase that patient or client's reserve and resilience? So older adults often live their daily lives at the edge of their physical capacity. The regular demands of their life, such as lifting groceries, getting up from the floor, going to a doctor's appointment, nearly max out their physical strength and endurance. And we hear that sometimes. She'll say, an outpatient might say, I can't come today. I had a doctor's appointment this morning. And you think, well, that doctor's appointment was at 8 a.m. It's 3 o'clock and you have to miss your appointment. It's because they've maxed out their resilience, their reserve. Approximately 30% of adults age 65 and older experience some muscle weakness directly related to living at or near their physical capacity. Resilience, and I've mentioned that word a couple of times just to review the definition, is the ability to withstand and recover from physical stress and fatigue. It encompasses how well one can maintain performance and return to baseline after encountering stressors, such as getting in and out of a car, getting up and down from the floor, playing with their grandchildren. And you hear people say, I'm just worn out. That should be a red flag for us as clinicians to think that person is living really close to their physical capacity, just on the edge. One thing happens and something tragic could happen, right? So we need to build, again, that resilience. Reserve refers to the excess capacity that individual can draw upon during peak performance efforts. So again, they have to have something like you need to get up to the floor. You need to draw on that reserve to get up from the floor. Individuals can significantly increase their resilience and reserve by stressing the body through exercise. And that will improve their 1 rep max. So that's not going to be a stagnant measure, just like with all our standardized measures, something we remeasure, and you're going to be able to see that 1 rep max is building as you're building their muscle strength and their muscle power. And the next slide. So interventions for patients without contraindications. So, of course, check the contraindications for your patients. I really ask you to research that with your residents or your patients and understand what their contraindications are. And we're going to mention those on the next slide of some suggestions of what they might be. But some interventions for you. And of course, this was one of the goals of our seminar today. So it could be on a test. High intensity functional training combines multiple joint movements with cardio and resistance training. It's designed to improve overall fitness and performance, such as cardiovascular endurance, strength, flexibility, agility, speed, and power. And that means maybe a circuit, right, where you would do different functional activities in a circuit and have a little bit of rest in between. Strengthening, you may initiate at a low dose of 40% of the 1 rep max when they're symptomatic, such as a painful joint muscle guarding edema, and progress to 60 to 80% of that 1 rep max. As a dosing, kind of progress of dosing by 2 to 10% of the 1 rep max when the patient is able to complete 15 reps. That's different in the literature. You might have learned increasing after 8 reps or increasing after 10 reps. This particular research said complete after 15 reps. So again, as a clinician, you make that determination of when to progress based on your research that you've done and also the response of the patient, of course. Power is a slow eccentric and a fast concentric movement. It's often something I see not being done in the clinic with older adults of doing an exercise in a certain period of time, right? Like a fast concentric and a slow eccentric movement. That's typically about 40 to 60% of your 1 rep max. So you can see when you're dosing how you're using that calculation of the 1 rep max, how you would use that in practice. And the next slide. So this is also interventions for patients without contraindications, and you'll see the little asterisk at the bottom, just some suggestions of what contraindications might be: acute or chronic heart disease, pulmonary embolism, DVT, any physical disability that precludes these exercises. You all probably guessed that already, but just wanted to include it. But talking about how do you understand or decide what exercises to use, I really encourage you to practice what we play. How often do you see a professional athlete only in the training room? They're an NFL player. They practice on the field, right? You have to practice what you play. So I would encourage you again to use exercise that simulate daily activities, such as a squat, of picking something off the floor. The deadlifts, lifting is similar to lifting a laundry basket or a grandchild. A loaded carry, like carrying a grocery sack, or pushing, like a loaded push, like pushing a grocery cart. Burpees, which I personally hate, but getting off the floor and being able to do that is really important. An upper extremity press, really lifting weights over your head, like getting something to or from a cabinet. Again, many therapists shy away from these kind of high intensity functional exercises, which are by definition functional for our residents. So I encourage you to integrate them into your daily routines with your exercise program for your clients. And the next slide. So just some tips on visits, dosing, exercise selection. First one's visit, and proper frequency is vital. We all know that to achieving our patient goals, yet visit compliance is one of the most voiced concerns in outpatient services. It may help to have a different conversation with your client. Viewing each visit as a dose of physical therapy might highlight that importance. So missing a visit is like missing a dose of your medication. To feel better, to move better, you need to take all of your meds, and that includes your dose of PT. So it's really important, and I think having that conversation with our patients or our clients and not saying it's okay to miss a visit might help, because how can you make those gains in muscle strength, muscle power, functional activity if they're not attending and they're not very compliant with the home exercise program? And the next slide. So dosing, that will change, of course, will change over the course of treatment, but challenging the patient's ability is really important. Stopping short of proper dosing will also cut short the overall outcome. Hint, 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 put down the 2-pound weight in yellow TheraBand. Unless you have really demonstrated that that 2-pound weight is that person's 1 rep max. Using it throughout the course of treatment with that 2-pound weight times 10 reps every single day, I think we could all agree that's probably not building up muscle strength. Also, if you're not doing any exercise under time, so you're really doing that fast concentric and slow eccentric, you're not building muscle power, which is one of the first things that older adults lose. It's not strength, they lose power. Exercise selection, again, practice what you play. Select exercises that stimulate and directly impact the functional movement related to the patient's goals. And communication, use our words wisely. We often decide ourselves as therapists when a patient rests. Maybe we've measured their physiological response to exercise and we know they can only exercise for 5 minutes and need a rest. But short of that, are we guiding it? Shouldn't the patients be guiding that? And so maybe change your conversation of, we're going to progress through this exercise regimen. You tell me when you need a rest. That's really important, that a patient understands when they need to rest. They're not going to have us at home all the time, right? So when they tell you they need to rest, you can assess their physiologic response. That becomes a documentable activity, right? You want to understand, is that moment when they stop you and need a rest getting better? Or is it getting worse, right? They're stopping you much shorter and their physiological response is becoming more of interest, right? That we need to look at what's going on with this. So letting the patient guide those rest breaks versus us guiding them is much more telling and much more advantageous to your treatment program. And with that, I think I'm going to pass it to Kim.
Hi, everybody. So my name is Kim Collins. I'm an outpatient senior area manager with Aegis. I've been an OT for almost 20 years, working with older adults, and I really enjoy this higher functioning adult population because we can really be creative and think outside of what the norm is for a lot of the OT scope. So when we're identifying the need for occupational therapy for these higher functioning adults, we have to look beyond the surface. We often have to sit down and have a conversation with our clients to find out what brings them joy and what they're having difficulty with. So I was screening a resident at an independent community for OT, and I had gone through my usual checklist of items, and she didn't have any trouble with bathing or dressing or home management tasks. And I was about to get up and leave when I asked her if there was anything that she enjoyed doing but wasn't able to do anymore. So she immediately starts to share how she couldn't play bridge anymore because she couldn't shuffle cards. And the bridge group at this community required that everybody had to take turns shuffling. So right there, it was my reason for picking her up for therapy. And I almost missed it because I didn't dig a little deeper and ask those questions. So we're going to examine some assessments and interventions. So the occupational profile, I know we heard about it all through school. It's a great way to make sure that you are maintaining a client-focused approach in your evaluation and your interventions by gathering information through both formal and informal interview techniques and conversation across all the areas of the client's life, including occupational history and experiences, patterns of daily living, interests, values, needs, and then relative context. And this is appropriate for all ages, regardless of where you're working. And then the Lawton Body Instrumental Activities of Daily Living Scale is appropriate to use with older adults, both in the hospital and the community setting. It looks at more complex skills than the CATS does, which is why I like it in particular for the higher functioning adults. It is a self-reporting assessment for the clients. So sometimes they'll either over or under report their skills. So it's good to back it up with some observation when it's possible. The disability of the arm, shoulder, and hand, or DASH, is a 30-item disability and symptom scale that assesses the client's health status during the previous week. And so it asks a variety of questions and about the degree of difficulty performing different physical activities, the severity of each symptom of pain, activities related to pain, tingling and weakness and stiffness, as well as those problems that interfere with social activities, work, sleep, and even self-image. So the questions within the DASH cover a multitude of subjects, anywhere from fairly simple things like feeding themselves to more complex things like playing golf. And there's even an optional module for work and playing sports. So as mentioned and covered great by Patty, the 1 rep max can be very helpful for determining the strength and helping direct strengthening goals and interventions. So we'll pause for a minute for our second polling question. So how are we looking, Shyla?
We have about 80% voted, so I will go ahead and close that. 3% said true and 97% said false.
All right. Well, the correct answer is false. Urinary incontinence is not just an older adult issue. It's a ADL that we often forget about and we don't like to talk about. But there was a 12-year study of over 15,000 women over the age of 20. 53% of these women had urinary incontinence, with the highest incidence of stress incontinence occurring in women between the ages of 40 and 59. 24% of these women also reported that incontinence affected their daily activities. So this is something that more than half of the women that you encounter are experiencing. So definitely something that we should talk about and address. So within Aegis, there are several resources in the clinical field resources in the SharePoint for continence. It includes 2 evaluation templates. So I just threw a couple of pictures up here. So the important items to remember when you're doing an incontinence assessment is to obtain specific information regarding frequency of leakage during the day and at night, the type and number of protection products utilized both during the day and at night, and then information about their habits such as caffeine intake, bedtime fluids, alcohol, and tobacco usage. So your interventions for the higher functioning adults should be very client-centered and based on the underlying impairments that are resulting in the functional deficits. As Patty had mentioned under the PT section, the high intensity functional training can be very beneficial for OT also, due to the varied functional exercises and various activity durations, which can simulate many IADLs, such as house cleaning and laundry. And so also remember, when you're addressing your IADLs and your upper extremities, focus on simulating those daily tasks and strengthening the muscle groups that are needed for those tasks, but not just the eccentric and concentric muscles that are required for the movement, but also address the stabilizing muscles, such as those around the scapula. Those are equally as important for strengthening. And then if you're addressing range of motion of the upper extremity, please be sure that you assess and address both scapular mobility and joint capsule mobility. If your joint capsule and your scapula aren't moving like they're supposed to, you can range the person all day long and you're not going to see the results. So when you're looking at continence management in particular, you want to progress your client after they've mastered the normal Kegels that are seated. You want to go from seated to standing. You can even pull out some ballet and do a standing plie. For those not familiar, that's when you're standing with your toes pointed out. You slowly bend your knees for an inch or two, and then you come back to standing. You're also going to want to incorporate muscle strengthening beyond the pelvic floor. So the abdominal muscles, all the hip muscles, and strengthening of the lower back, those all overflow and help with pelvic floor strengthening. So now, Jenny is going to share some information about how speech can work with the higher functioning older adults.
Hello, everyone. I am Jenny Blankenberger, and I am an outpatient speech and language pathologist for Aegis. I have just been with Aegis for about half a year now, but I have been a speech and language pathologist for 13 years. I've worked in almost any setting you can think of, from the skilled nursing to early intervention, assisted and supportive living facilities, outpatient, and PRN in like acute care. So currently the majority of my treatment time is in the outpatient setting. And I like to say that I find joys in all areas of the SLP world. This population, the higher functioning person, is one of my favorite populations to work with because they're often very motivated. Our treatment sessions can be very functional, and we see a lot of really functional progress that applies to their daily life immediately. So we're going to go over some identifying who those people are, assessing what their needs might be, providing their person-centered interventions, and improving their independence and quality of life. All right, we'll go on to the next slide. And PT and OT individuals on this call, you might think, oh, this is for speech, but a lot of this information is going to be really helpful for you too. You are sometimes the first individual who might see these difficulties in these patients that you see and can help refer them to your speech therapist to get the help that they need. So who might these people be? This list of diagnoses is not exhaustive. I just wanted to give you an idea of some of the diagnoses that I've encountered that have resulted in difficulties with the higher functioning individual. Most recently, I have seen an increase in people with post-COVID and oftentimes cancer-related cognitive impairment, but a lot of these diagnoses you'll see in your PT and OT practice as well. And then the what. So what would we look at during a cognitive communication evaluation for this population? We want to see executive functioning is a huge one. Their social communication skills, their problem solving, their memory, and attention. A lot of times I say that they're going to need to be able to do anything in life that I would need to do on a regular basis. These people might still be working, raising kids, babysitting grandkids, driving, and managing their own finances. Next slide, please. So for you PT and OT individuals on the call, what might a person with higher level cognitive issues look like in your sessions? They might have more difficulty following the complex directives that you're going to give them. Maybe they have trouble managing their schedule to get to therapy on time or grasp a change due to a therapist being off work due to illness. Maybe you're not seeing good carryover of their home exercise programs, or you're saying, I'm having to retrain them on this exercise over and over again. Maybe they're having difficulty communicating with you while completing their exercise tasks, or just difficulty finding the words. And they'll often say, oh, I can't think of that word I want. So those are just a few of the things that you might see in your treatment sessions. And again, you might be some of the first individuals to recognize that these people are having difficulty. Next slide, please. And then at home and in the community, what might these look like? This may look like unpaid or late payment of bills, difficulty making their appointments to the doctor or anywhere else, appearing more unkept, maybe asking someone else to make the decision instead of them, decreased participation in typical tasks. Maybe they like to go to coffee with a coffee group, or they like to go to Bible study, or they like to attend exercise class, and you're not seeing them there as often. Or maybe they're having difficulty managing their mail at home. I had a patient come to see me who noted that she was taking a lot of time to organize her mail. She was missing paying her bills because she was accidentally throwing her bills away and not being able to recognize what was junk mail and what wasn't. Next slide. They might be having trouble with medication. Medication management can be very complex. Maybe we're seeing difficulty in their abilities because they're not taking their medication accurately. Maybe they're telling the same story every once in a while without realizing it. They're not managing their money well or having more errors in their checkbook. There was a recent study that showed that we were able to see changes in individuals who were later diagnosed with a cognitive impairment, dementia, Alzheimer's, anything like that. 6 years prior to their diagnosis, we saw changes in their money management abilities, in their banking status, in their money usage. So 6 years prior to that, there were probably these small errors happening that nobody picked up on. Difficulty following a recipe or making food at home, leaving the oven and the stove on, forgetting names of people, or this is a more complex task, difficulty planning a party or an event. Next slide, please. So how do we, those are just some things that we might be able to quickly identify someone who's having a little more trouble with higher level and complex cognitive tasks. So how do we assess that? Well, we need standardized assessments. They're important because often they're required for reimbursement with insurance companies. They're norm referenced and they're standardized, and they can be easy to administer once you're familiar with them. So I picked 3 of my favorite assessments that I feel really get into more complex and higher level questions. So the cognitive linguistic quick test is truly a quicker test to give, which is why I included it today. And it assesses attention, memory, executive functions, language, and visual spatial skills. A couple things that I like about this assessment is that there is an aphasia administration. You may have someone who had a stroke and is still very independent and very high level, but does suffer from aphasia. And it also has an effective tool for Spanish-speaking adults, excuse me. Next slide. The next one is the scales of cognitive and communicative ability in neurorehabilitation, which is also called the SCAN. I really like the SCAN and have been using it for a very long time. In my opinion, it takes that full 45 minutes for administration, so make sure you have enough time. But it really looks at oral expression, orientation, memory, speech comprehension, reading comprehension, writing, attention, and problem solving, which are all things that we need to be able to do to complete our daily activities throughout home, community, and possibly even work. Next slide. And then the last one is the FAVRES, the Functional Assessment of Verbal Reasoning and Executive Strategies. This one was new to me in the last year, but I have grown to really enjoy it and feel like it really assesses those executive function skills that are so important for our complex abilities. I do feel like it takes the full 60-minute time to complete, so make sure that you have enough time to do this one. Next slide. It also looks at 4 activities. So the whole assessment is 4 activities. You'll plan an event, they'll schedule a workday, decide on a gift, and build a case to solve a common problem. And those are all very complex. I actually took the test myself, so I would understand it better to be able to give it, and it was quite difficult. So I have found that this test really shows deficits in those more complex individuals if I'm struggling to find that in a regular or a different assessment. Next slide. So although standardized assessments are great, They don't always give us a clear picture of the functional person. They're not always culturally relevant, and they can be intimidating for the individual doing therapy with you. And that's where these patient-reported outcome measures, contextual observations, and role play can help and really put together that full picture of the individual in front of us. This allows our cognitive assessments to be person-centered, collaborative, and functional, which in turn allows for patient choices, increased motivation, and then patient buy-in and participation. I listed a few examples of different patient-reported outcome measures that I have found to be very beneficial in my treatment sessions, and I would really encourage you to familiarize yourself with them. Most of them can be found online for free, which is always wonderful. Yes, perfect. Now, here's some extra questions that I have used in my therapy sessions that I felt like could be beneficial to you to help give you just a list of things that you might look over with that patient. I find that sometimes individuals don't even realize that they're having more difficulty with something until I ask them about it. So I like to initially leave the question open. Tell me why you're here. What are you struggling with today? But then I have a list of questions that I can refer to and really check more in depth. And a lot of times they'll say, well, you know, I am having a little more trouble with that. I also like to note that a lot of these questions are more interdisciplinary. So although, yes, as a speech therapist, I am going to be asking these questions, this is a great list of questions that anybody could ask during their sessions, during their assessment with that individual. And then the last question on this page, what brings you joy? I love that Kim brought that up in her her portion as well, because that is one of my favorite questions to ask. We really get into what matters to the person, and that's what's going to be most functional for them. So what brings you joy is one of my favorite questions. Next slide. And then I included some more questions or some more prompts that you can provide to the patient to get deeper into what they might be struggling with. So that way your goals can be more functional and specific to what their true needs are. Next slide. And then here are some even more. So as you can see, I have a long list of things that I like to ask about to make sure that we are looking at the individual as a whole. And these might not be addressed fully on our standardized assessments and our patient-reported outcome measures. So finally, as we get to the treatments and interventions, I want to briefly touch on 3 research-backed interventions that can be applied to all domains within cognitive communication skills. We know that because of neuroplasticity, we can make functional changes within our brain to improve our cognitive communication abilities, as long as we make sure that we have specificity. So we're training the specific thing we're working on, it's functional, and we have lots of repetition. So metacognitive strategy training, this is to observe and evaluate one's own thinking. So to think about thinking. We can increase neurocognitive awareness. We want to think about how we got to an answer rather than the answer itself. So this helps us to increase our self-awareness, our ability to self-correct, our thought processing, and our problem solving. When we can increase our metacognitive skills, we can improve accurately choosing and using appropriate strategies within our daily tasks. And then within this, we can use something called Socratic questioning to increase deeper thinking and reasoning skills. When we improve someone's metacognitive skills for understanding what skills are needed to complete a task, we can have them make a plan for that task they want to complete, and then have them actually complete the functional task, and have them assess how they did, identify, and then fix the errors, and identify strategies to improve better completion next time. Dual tasking is a fun one, especially to involve our PT and OT cohorts. This would be training 2 tasks at once to improve the idea of multitasking. So with PT and OT, we could complete a motor task while also completing a cognitive task. So recalling details of a short passage while balancing, or explaining the steps to completing a work task while on a stationary bike. And then last, we have memory strategy training. These are strategies that each of us already use to successfully make it through our days. I've used strategies throughout the whole day. Excuse me. We have internal memory strategies such as visualization, association, rehearsal, mnemonic, chunking, and elaboration. Now remember, these need to be practiced in real life functional contexts. And then we also have external memory strategies such as notebooks, planners, checklists, visual aids, timers, alarms, phones, computers, the list goes on. These are most beneficial though for compensation when we're using them. We want our external memory aids to be easily accessible and unique to the individual. So an example is I had a patient who was forgetting specific things he needed for the day when he was leaving the house. He used both an internal strategy, so he made a poem to recite to himself before he left for the day, and he used an external strategy. He placed a list of must-have items on the door so he'd see it before he left the house. Another patient had difficulty recalling the names of her grandchildren, so we would use internal memory strategies during the session, and then she would take an external memory strategy home with her. I provided a few more interventions there that I have found to be most helpful within my therapy practice. And the one I probably use most often is the goal plan, do, review, and revise. But piggybacking on what Patty said earlier about the physical capacity in reserve is very similar to spoon theory. And that's with cognitive function, knowing how much cognitive reserve we have to use throughout the day. So I thought that that was neat that those two really go together. So I did add a little statement at the bottom that unfortunately research has shown us that improving an impairment without making it functional does not mean someone's participation will also improve. So we want to move away from those brain games and those workbooks and really be as participation focused as we can to ensure that person-centered therapy. And now I have a polling question for you guys. So what is an evidence-based treatment intervention for higher level cognitive deficits? The Baker treatment strategy, metacognitive strategy training, expansion training, or none of the above? How are we doing, Shyla?
It looks like about 65% have voted, so we'll give them a couple more seconds.
Okay.
All right, I'm going to go ahead and close it. 5% said Baker treatment strategy, 78% said metacognitive strategy training, 8% said expansion training, and 9% said none of the above.
So we want metacognitive strategy training for today. And I'll leave you with one more, a little tidbit of information. A few great resources that I refer to often are the Honeycomb Speech Therapy Activity Studio, which is online. And they have great resources for you as a therapist and for patients. And then also the Med SLP Collective has wonderful resources, handouts, and trainings that are very pertinent to this topic that we're talking about today, and where I find a lot of my resources for my trainings or for my treatment sessions as well. And I'll turn it back over to Jay. Thanks, everybody.
Okay, so I have everyone's favorite topic, documentation. And the reason for referral is the most important element of the therapy evaluation for supporting medical necessity. At the heart of the reason for referral is the description of what changed and why, which will begin to make the case for why the patient is being evaluated. Most payers' coverage guidelines indicate that therapy services are covered when intended to impact function in some way. The functional issues for which therapy is directed must be meaningful to the patient. It's important that we are asking patients probing questions to find out how their current issue is impacting their life. And don't accept it when they say, I can do everything. Probe deeper, because it will be important to find out how their function is impacted. Maybe it's that they no longer sleep through the night because of pain, or it now takes much longer to complete basic housework because of having to take frequent rests. And describe these types of concerns in the reason for referral. So documenting standardized tests, don't limit the reporting of the standardized test to just the score. A good example of this is the DASH. There's several examples of this, but when Kim was talking earlier in OT, I thought of this about the DASH, the 30 subsets. Some EMRs aren't going to allow that. So, if the test assesses different activities, it's best to include the actual scoring for each activity in the medical record. If that's not possible because of your EMR, describe the test elements that showed the greatest challenges or impacted the less than desirable score the most. Provide an interpretation of the test and explain how the results will be used in the treatment plan. And of course, ensure long-term goals are focused on function or the objective risk identified. Next slide. Describe your skilled procedures and interventions that only you as a therapist or assistant have the knowledge, education, and expertise to provide. Those that an aide or a caregiver or the patient themselves could not do, perform safely, or be instructed to do. Activities and tasks sometimes start out skilled in the beginning when an activity is new to the patient, but eventually, many treatments become repetitive. Repetitive activities, tasks, exercises, or cues are generally not considered skilled. This is because repetitive activities, tasks, exercises can be taught to the patient to do on their own or taught to someone else who is not a therapist to cue or help the patient. Once an intervention can be taught to the patient or their caregiver, it no longer requires the skills of the therapist to perform the task, and it should be transitioned to the patient and or caregiver for continued performance. So that concludes the lecture portion. Just a couple of housekeeping reminders again. Now is the time to use the questions feature of GoToMeeting to ask questions and provide any comments. Please make sure you logged in with your own unique identifying login, because if you're sitting there watching somebody else's monitor, we won't know that you participated. Please give Shyla up to 2 weeks to process the certificates. Speech therapists, please remember to submit your ASHA bubble sheet. And OTs, be on the lookout for the quiz. The quiz that you have to take. Sorry, I accidentally muted myself instead of turning my camera on. So now we'll turn it over to Shyla.
Awesome, thanks, Jay. There are a couple of questions already. You can go ahead and start putting them in now, but the first one is, what constitutes chronic heart disease?
Ooh. That's I'm sorry, go ahead, Patty.
No, go ahead.
Well, I would say it's heart disease that is not acute. It's not an acute episode. This long-standing. I don't know the exact definition offhand of chronic heart disease. If there's that timeline that it would need to be an existing condition to be determined chronic. But I would also add that if you are torn between whether a condition or diagnosis is chronic versus acute, reach out to the physician for clarity, because that is not your decision to make, and you don't want to make any assumptions.
And I would ask them about precautions for exercise while you're making that based on that condition, because it's so general. So.
Okay. The next one is, can the CLQT be given by OT or only ST?
Ooh. I'm not familiar with that one. So Jenny, does that require any kind of certification or?
It does not require certification. I know I can give it as a speech therapist. I'm not sure about OTs.
I have never heard of an OT delivering it. I have reviewed a lot of documentation in my day, and I have not seen that in any OT documentation. But at the same time, that's not proof. So I would have to research that further myself. But I know myself being an OT, I would not be comfortable doing it. I would probably defer to speech.
Agreed.
Okay. The next question, I can kind of answer that. Are there any other CEUs coming up? Yes. Aegis hosts this particular webinar, not this course, but it's called Impact with Aegis, once a month, and it is on the third Wednesday of every month. So yes, we have one every month. Yes, certificates will be sent via email. And the QR code is in the handout section where it says handout for the OT and CODAs. That's where you can find the QR code for that quiz. If you can't find it, an email will be sent out tomorrow. All right, you don't have to sign in, guys, with your name specifically, only if you're sharing a screen with someone else. If you use your login to get on this webinar, that's fine. It keeps up with it electronically. There's nothing that you need to sign or anything like that. There's nothing that PTs need to fill out for credit. You will just need to keep your certificate to send that in.
Lucky PTs.
Really quickly about the CLQT question, I did find that it just says that it can be given by an experienced clinician. So I think that since cognition falls into occupational therapy, I would say as long as the therapist is familiar with the test and familiar with the areas of cognition, that it would be appropriate. But I think before an OT would give it, they should research that a little bit more. But that was just my quick overlook of what the test said. So.
Thanks, Jenny.
Where's the syllabus found? It's in the handout section. And the bubble sheet is also in the handout section. And I think that is all the questions we had.
Thanks, Shyla, for monitoring that.
No worries.
Thank you.
If anyone has any other questions on the back end, feel free to email me. It's Shyla, SHYLA.Hamrick, HAMRICK @aegistherapies.com, and I'll be happy to either help you myself or direct you to the person that can answer it.
Thanks, everyone.
Thanks, guys.
Thank you.
Thank you.